Okay, I think we're ready to get started here. Looking at our schedule for this week and leading into next week, of course, we're leading up to exam 3 next Monday, a week from today. We're well ahead of schedule, as you're well aware. Keep in mind, we're going to do some kind of clinical correlations with the lower and upper limb this week as well. As someone asked me at the end of class, that won't be covering necessarily any new information that I'll be expecting of you on the exam. Rather, it's there to kind of emphasize and complement what we have talked about in class and provide some more glue for some of the very basic anatomy to stick in your minds. The quiz tomorrow, we do have an in-class quiz tomorrow. That'll cover material up to the elbow. So not the elbow and beyond. Again, we're a little bit ahead of schedule here, but up into the elbow is what, upper limb only, first part of the chapter through the elbow. It does include the brachial plexus, potential injuries there, includes, muscles and their actions and innervations for the arm and the shoulder region. Those sorts of things would be the material to be for the quiz tomorrow. Any questions on any of that? Questions on that?
So not the forearm?
Not the forearm. Not the forearm or today we'll be going through the wrist and the hand. That will also not be on there. Okay. Austin is currently scheduled for Thursday. We'll kind of go with that. Not Thursday, Wednesday. Any questions about anything else going on in class or otherwise? Okay. Wednesday lab quiz focusing on the lower limb. Of course, that also on your radar. Well, if there's nothing else, let's go ahead and have a word of prayer, and then we'll just go ahead and get started today. Let's bow our heads together. Father in heaven, just ask that you be with us as we study the anatomy of the hand. And Lord, again, we're just so blessed, and we thank you for the opportunity to be here, be with each student as they continue their preparation this semester. In Jesus' name, amen. All right, well, let's take a look here at where we left off. I think we're in part 2 of the upper limb, is that right? I believe. Right here. We had just kind of wrapped up some of the muscles of the forearm. Keep in mind, I'm certainly not meticulously going through every single muscle and just kind of, because there's a lot of rote memorization in here, and I think that would perhaps bore us to tears at moments. I am relying on you to go through those charts, as I've said from the very beginning for the lower limb. The charts for the muscles of the lower limb and upper limb, every muscle, every innervation, and every action. If you need any clarifications on that, happy to clarify. Someone just clarified before the class began about, do we need to know, for example, on the interossei branches of the radial nerve, when it comes to the muscles that innervate, so we need to know that differentiation? No, I'm not going to be asking you to differentiate between those two branches. I will be asking you to differentiate between what muscles the radial nerve innervates versus any of the other nerves. That'll be the focus. Make sense? Okay, feel free to ask questions if there's any clarity needed. By the way, I think we'll end up with some time this week also for review. So as we get closer towards the end of the week, especially, you might want to have some review time. I'm happy to try to make that happen too. If you have questions, of course, you want to go over. Okay, so new material. As in the lower limb, when we're looking at adduction and abduction of the fingers, we have to arbitrarily draw a line. And in this case, the arbitrary line is on the third digit, the middle finger. That's this dotted line that we see going down here. And when the digits are moving towards that middle finger, then it's adduction. When it's moving away, then it is abduction. Okay, so that's the new dividing line. Now, when it comes to the bones of the wrist, again, probably not going to go through every single one of them, but I will highlight some key ones that might be of special note to our class. First off, let's focus in on these carpal bones. There are 8 bones that make up the wrist. they are roughly arranged in 2 rows. I say roughly because it's not a very clean and orderly 2 rows, but nonetheless, they're roughly ordered in 2 rows, one being closer to the radius and the ulna, another row being closer to the metacarpal bones. Now, one thing I want to point out about those carpal bones and their arrangement is if you look at the bottom of this image, they've taken a cross-section of the carpal bones, and what you're seeing here is there's actually something called the carpal arch. And that's because these bones, they're kind of U-shaped in how they're arranged, and it ends up forming, with the flexor retinaculum over the top, the carpal tunnel. So the bones are kind of U-shaped. This is towards the anterior side, so towards the anterior side of the wrist. That's kind of the open side of the U, is towards the front. And then over the top of that, there's going to be something called the flexor retinaculum, and that's going to cover the top of what's going to be called the carpal tunnel. Now, at the wrist, let's go ahead and talk about the most common fracture in the human body. This is often referred to as a Colles fracture, just another eponym maybe to be aware of, Colles fracture. It's when someone falls upon an outstretched hand, which of course is all of our instincts. When we're falling, we're going to put an outstretched hand out there. When you fall on the hand like that, often what will happen is fracture not of the actual wrist bones themselves, not of the carpal bones, but rather the very distal ends of the radius and potentially also the ulna. Something to file away associated with that kind of a fracture is whenever there is overriding of the proximal portion of the bones to the distal portion that they've broken off from, you end up having kind of a part of the wrist that will stick out because now you've got a broken end of the bone that's pushing on it. That's often called the dinner fork deformity, that occurs because the end of the bone cleanly broke off, and then now it's kind of uneven and almost resembles, when you look at the side of someone's hand, almost resembles a fork. Okay, any questions on the Colles fracture or anything associated with that?
Is Colles both or just the radius?
Colles specifically, it's just the distal ends here, and I think it can be used to refer to either just the fracture of the radius itself or in combination with the ulna. If only one is fractured, most commonly, it's always going to be the radius fracturing by itself. And then sometimes when the force is high or the bones are weak, you might actually fracture both of them. Good question. So, another fracture that I'd like for you to be especially aware of in the wrist, it's an important one, is one of the carpal bones, the scaphoid bone. This particular bone sits right underneath, it's one of the bones, it sits right underneath the end of the radius. It sits right underneath the end of the radius. That's on the thumb side, of course, so the side towards the thumb. And there's something unique about the scaphoid bone that makes it a problem if it does happen to get fractured. And that is the blood supply, as they have so nicely illustrated in this slide. The blood supply for the scaphoid bone goes actually around the bone and comes in kind of the distal side of the bone and works its way back proximal. Okay, so it actually comes in kind of the further end from the bone and then works its way backwards. What does that mean when it comes to a fracture? As we've mentioned before, fractures can sometimes interrupt blood supply, and in this case, if it interrupts blood supply, this is definitely one area, and they've even shaded it kind of a darker color there, where you could experience avascular necrosis of that proximal portion of the scaphoid bone. So this is something that sometimes is screened for. One of the reasons that you might do a radiograph in the area of a wrist just to kind of rule out any fractures here. And of course, if there are fractures, very careful monitoring to make sure that that didn't result in interruption of the blood supply. This image is a radiograph, and what we're seeing is, again, if you're looking at radiographs, you're trying to figure them out, I always orient myself and first look at the end of the radius. It's much larger at this end than the end of the ulna. And then the scaphoid bone, it's nice and oblong, and it always sits over towards the thumb side, so towards the very lateral side of the wrist. On the one I've been drawing on, that one's an intact scaphoid bone. There's no major issues, but of course you can see a nice fracture that's there on the image on the right down the middle of the bone. Okay, that leads us to the actual carpal tunnel. So we've got a very nice cross-section of the wrist. Again, we have these U-shaped carpal bones arranged together. Over the top, there's another retinaculum. You remember us talking about retinaculum both in the lower limb, and then we talked about extensor retinaculum just the last class period, or it was mentioned in the video, one of the two. Well, of course, the flexor retinaculum is a flat, broad membrane that's going over the flexor tendons that are heading into the fingers. Specifically, I would like you to know the contents of the carpal tunnel, which is not as bad as it might seem. They're bolded here. We've got the flexor digitorum tendons, and there's a whole bunch of those, obviously. There's 8 of them. There's the superficialis and the profundus. Both of those pass through the carpal tunnel. Remember, those are going to flex digits 2 through 5. In addition to that, we also have another flexor, the flexor pollicis longus tendon. Lastly, when it comes to items that are truly encased within the carpal tunnel, we have the structure that causes problems, and that is the median nerve. The median nerve passes through the carpal tunnel. Now, what should be going through your mind, of course, as we think about the carpal tunnel clinically, is carpal tunnel syndrome. And this is a case where pressure builds up within the carpal tunnel and ends up impinging upon the median nerve. That pressure comes from repetitive use of the flexor tendons. The most common way that we might think of that is in typing extended amounts of time. When someone uses their fingers and of course they're typing or something like that, they'll be flexing those fingers all the time. As they use those fingers frequently, often it is thought that micro tears develop within the tendons, little tiny micro tears, microscopic. Those micro tears nonetheless need to be healed up, and in that healing process, inflammation develops within the carpal tunnel around those tendons. That inflammation that develops begins to put pressure on the nearby structures, including the median nerve. For now, in the next few slides, we'll actually see all the details of the median nerve. For now, know that the median nerve, as it passes through the carpal tunnel, the main thing it's going to do in the hand is both give motor innervation to the majority of the muscles that control the thumb, intrinsic muscles of the thumb. In addition to that, it's also going to have some sensory innervation it's pulling back on the same side of the hand, on the thumb side of the hand. So, carpal tunnel syndrome, what you should be very aware of is you're going to potentially anticipate seeing weakness or even atrophy of those thenar muscles. On your hand, I don't think we've seen the slide yet. It'll be at the very end of the chapter, but you have a thenar eminence on your hand. The thenar eminence is this big bulky base of your thumb where these intrinsic muscles of the thumb reside. There's also a little bit of a bulge on the outer side, the hypothenar eminence. In people with carpal tunnel syndrome, this will start to shrink a little bit, and their thumb will be weaker on that side as a result of those muscles not functioning well. They will also lose some sensory innervation on that side of the hand. I'll give you the exact layout of that sensory innervation on a future slide here. Questions about carpal tunnel syndrome at all? Any questions about the anatomy or the kind of the layout here or the causes? Yeah.
So when they repair this, are they just like pulling back up that retinaculum?
Yeah.
Is that
Yeah, it's a great question. It's called a flexor retinaculum carpal tunnel release, and they literally cut the flexor retinaculum right down the middle. They just slice it open. That's released. Now, keep in mind that does mean that the tendons are going to tent up. Remember, the whole purpose of that flexor retinaculum is to hold those tendons down. That's going to mean those tendons are going to pop out quite a bit more whenever those forearm muscles that are heading in are being flexed. But obviously there's already problems and that the person's getting weak and all that, that's going to help. It's going to produce more room for the structures, especially the median nerve. Yeah. Good question. Okay. So there's the carpal tunnel. Got the contents of that down pretty good. Let's look at another space here. And this is the anatomical snuff box, quite literally. And I don't know if I can show you. I was thinking about trying to show you with my, see how fancy we can be here. I can probably just lift my hand up and do it, but why not try to use some technology, right? Let's see if this poor camera can pick up. It's kind of dark. Let me just pick this on. So if you look at my hand for just a moment here, so there's my hand. If I take my thumb and I really extend my thumb as though I'm trying to point my thumb towards the top, and you can do this on your own hand right now, you'll notice there's a gap that develops between two tendons right in there. And it's actually a little gap. It actually is a little spot. And it's called the anatomical snuff box because, yes, if you were going to snort something, and I would only suggest, of course, legal and appropriate substances, people used to put that into that and snort it into their nose. And that's the reason why it's called the anatomical snuff box. Now, besides teaching you about your own anatomy that you didn't realize that you had a built-in snuff box, what's the purpose behind that? There's two things I want you to know about the anatomical snuff box that are important. Two things. They're not hard. One of them is beautifully illustrated on this slide, and that is the radial artery. As it goes past the wrist, it actually drifts right underneath the anatomic snuff box. And if you relax your wrist, you can actually reach right in that same spot and palpate that radial artery as it goes past that location as well. So radial artery is present there. The second thing that's present there, and this is also good to know, is the scaphoid bone. So I talked about the scaphoid bone earlier, the one that, if you have a fracture, it potentially can have the necrosis there. It actually resides right at the same spot underneath the radial artery, roughly. And if you press in, that's actually where you palpate the scaphoid bone to try to determine with a clinical examination about the fracture and potential pain there. You actually push right in on that location to palpate that bone. Okay. Oh, and then I guess I should have mentioned the tendons that you were looking at going by there, just so you're very clear on these. These are a couple of the extensor muscles for extending the thumb. Extensor pollicis longus being, one of those, and then the other one is the extensor pollicis brevis on the other side. Okay. All right. I think that wraps up that section. Any questions while I pull up part 3 of the upper limb here? Questions there? Okay. Well, now let's talk about the muscles of the hand. Yes, there are quite a few of them. The good news is they're very similar to the muscles of the feet. If we looked at those, those translate over quite well. I'm going to primarily focus on the pattern of innervation, and hopefully that'll be a pretty good kind of roadmap for you as we study these muscles together. So, pattern of innervation. First thing I want to note is that the ulnar nerve is going to be doing the bulk of innervation of the muscles that are intrinsic to the hand. Keep in mind the ulnar nerve hasn't been doing a whole lot along the way. Picked up a couple of muscles in the forearm, but other than that, its main job is heading into the hand and doing the intrinsic. Now, it does actually have a deep and superficial branch, and for those who want to keep score, I don't believe I'll be focusing on that overly much, but nonetheless, be aware that the ulnar nerve's superficial branch really only picks up one muscle, and that's this palmaris brevis muscle. The rest of the muscles that are innervated by the ulnar nerve is going to be always the deep branch of that ulnar nerve, catching all the rest of those. So that's just one small differentiation in the hand that's worth noting. So that would include, for example, the interossei. So the interossei are similar to the ones we saw on the feet. They help with abduction and adduction of the digits, depending on which side is obviously being pulled on. Deep branch of the ulnar nerve innervating those muscles. Now, there's also a muscle here, this adductor pollicis. There's two heads to it here. And the deep branch of the ulnar nerve also innervates the adductor pollicis as well. Now, the reason why I mention that is actually because on the next slide, I'm about to show you that all the rest of the pollicis muscles, and maybe I should just go ahead and show that to you, which include these three thenar muscles, the flexor pollicis brevis, the opponens pollicis, the abductor pollicis, all the ones that have the pollicis name in them that are intrinsic to the hand, located within the hand, those are actually innervated by the median nerve. And those would be the muscles, those three would be atrophying whenever the median nerve is being impinged upon and not able to do its job properly. Specifically, and I'll go ahead and even mention this just because it's worthy of note, it's just one small portion of the median nerve that branches off to give motor innervation there. There's actually a lot of branches of the median nerve. These are all branches right here, and they're all going to be sensory going to the hand, picking up sensory information. There's just one, very small. It's called the recurrent branch of the median nerve. This nerve here heads over and does those thenar muscles. Now, of note, I guess, I'll just go ahead and say this. In any sort of hand surgery, I remember having Dwayne Carlson, the orthopedic trauma surgeon, come in during his orthopedic training. They always referred to this as the $1 million nerve. He says with inflation, it's about the $5 million nerve now. You can probably guess why, and that is it's a very delicate little nerve. You're operating in the hand. You clip that nerve, you just paralyzed a good chunk of the thumb. Obviously, we use our thumbs a lot for a lot of things, and it could end up with a liability lawsuit in terms for the surgeon. So, $5 million nerve. By the time you guys get done, probably the $10 million nerve. I don't know. I have no idea. Nonetheless, very important little nerve going over to innervate the thenar muscles. Thenar muscles. Okay. Now, one other thing I'll note, and this is again kind of trying to differentiate the median versus the ulnar innervation here. The last thing I'll note about that, the lumbricals are actually split. The lumbricals are split. And that is the first and second lumbricals are actually innervated by the median nerve, whereas the ones that are past there, the third and fourth, those are actually innervated by the ulnar nerve. So there's just a few exceptions to the general rule, but the oversimplification is the intrinsic thumb muscles go with the median, everything else goes with the ulnar. If you have the couple of exceptions that we've noted, you've got the innervation of the hand pretty much down. Okay? All right. Now, I actually, I'm kind of, maybe I'll even mention this about that, and that is, do you guys remember in injuries of the lower brachial plexus, we talked about, actually, let me switch that around. Let's go to the upper brachial plexus. Upper brachial plexus, let's focus on the ulnar nerve. Whenever we had injuries to that, I mentioned that the claw hand would be a potential consequence of that. And I kind of critiqued the hand that they had there, like they had just kind of like a claw kind of thing. But I was trying to say, no, it's not exactly a claw. It actually looks a little bit more like this, where the fourth and fifth digits are really curled over, but these are not quite as much. The reason for that is actually the innervation that we just talked about. Turns out the lumbricals on the first couple of digits are covered by the median nerve and would not be damaged if the ulnar nerve or that area of the brachial plexus was being impinged upon. And so they actually get to hold those fingers a little bit more intact, whereas the fourth and fifth digits curl up because essentially all the intrinsic muscles have been paralyzed in the hand, and the flexors from the forearm pretty much take over and just pull those guys right on down. Does that make sense? Yeah, I just want to, I mean, just to kind of put some more pieces together, make sense out of it. Okay. Blood supply to the hand. Kind of nicely, they've laid out, it's coming from two arteries, the radial and the ulnar. If I'm following them from the wrist, definitely note that they anastomose with each other. Actually, usually there's a couple of arches. Here's a superficial palmar arch. Underneath it, there's a deep palmar arch that connects both of those arteries together. From there, branches come off and go in between the digits with roughly the thumb and half of the second digit being supplied with blood from the radial artery, and roughly half of the second digit all the way over to here to the fifth digit being supplied by the ulnar artery. Now, I don't know if you guys have done this at all in your Hicks picks or not. Tell me if you've done like the Allen test, or for those who have worked in doing arterial blood draws. Yep, right there, arterial blood draws. What the Allen test basically does is it tests for, are these arches connected? And the reason why you might want to do that test is if you're doing any procedure in which you're going to enter the artery, either the radial or the ulnar, and this might be for something as simple as an arterial blood gas draw. So you're going to pull some arterial gases. You want to see what that is. Well, if that arch is not intact, you might accidentally clot that artery off. And if the arch is not intact, then now you've clotted off the end of that artery, and now you've just killed, through necrosis, all the distal structures that artery is supposed to be supplying. So that'd be terrible. So the Allen test says, okay, is the arch intact? It's actually really easy. You can almost, it's harder to do yourself. It's much easier to do someone else. But basically what happens is you get all the blood out of the hand, and so you squeeze the hand like have them pump their fist, right? And of course what that normally does is it blanches your hand, and then your hand's all white, and then it'll, as the blood rushes back in, it turns pink again. Well, to test each side, basically you have the person squeeze their hand, get it all blanched, and then by putting pressure, usually with your thumbs, but by putting pressure on both the ulnar and the radial artery, and then have the patient relax their hand and then release just one side, and you can alternate which side you're doing, you should see the blood get back into the hand from one side, and like a wave of red should come from one side to the other side, and then vice versa, a wave of red from the other side going back. If that happens, you go, oh, okay, well, they're like 95% of the population. They have these arches, they're intact, we're good to go. We can now insert this catheter that we were going to insert anyhow, or whatever else we were doing, and we have no worries. Of course, if it doesn't, then there's additional questions. You got to figure out, well, what are we going to do now? Because there's not an intact arch. Okay. Any questions about the blood supply to the hand? Oh, and also note, and I think you guys remember this from the toes, but the arteries in the fingers are on the sides, right? On the lateral aspects. They are not on the anterior or posterior side. Again, when you think about deep cuts and all that kind of stuff, where you really are worried about cutting an artery is if they cut the sides of their fingers, not quite as much on the front. It's obviously possible to get it there, but you have to be pretty deep. And the bone itself is actually helping to protect those structures, as well as the branches of the sensory nerves that are in the same locations. Okay. I think these just show kind of the layout of those arteries against the muscles and the surrounding structures. Don't think I have too much else to add to those two images. Let's go ahead and talk about the venous drainage of the hand. So we have a dorsal venous network. So on the back of your hand, if you just look at that, you can often pick up many veins that are there. A highly variable pattern that's there. We don't name any of those veins because it's just so variable. We just call it the dorsal venous network. The dorsal venous network, however, will consolidate into our good friends, the cephalic and basilic veins. Cephalic vein on the thumb side, basilic vein over on the side of the fifth digit, and we've followed those guys in previous lectures to their destinations. Now, I will take just a moment and talk briefly about And just for these nerves, just 3 nerves, we're going to talk about the sensory, these aren't really technically dermatomes. These are the areas of the skin that are particularly picked up in the hand by 3 nerves that get down in that area. And the reason we're going to do this is not uncommon, and maybe even in Hicks-Picks you touch on this. You can test these nerves by testing these sensory areas, and also it predicts, for example, when things go south with a brachial plexus injury, or when things go south with a carpal tunnel syndrome or something, helps to better predict, okay, that's where we would expect when I have a deficit in the median nerve, where we would have issues. The first nerve we're going to take a look at is the ulnar nerve. So the ulnar nerve. And there's a couple of branches of the ulnar nerve. I'm not going to ask you to, as we've tried hard to kind of ignore the branches for the most part as a general rule. We're sticking with the main nerve for each major thing here. With the ulnar nerve, you'll notice that it is out towards the 5th digit. So both on the front and the back, it's covering the 5th digit, okay? Now on the 4th digit, it's a little bit wonky. This is probably the wonkiest thing ever. It is true though, and it's very consistent. And that is on the anterior side, that's the top of this image, it is picking up sensory information from that more medial half, the half facing the 5th digit there. Take a look here on the posterior side. It actually does the entire posterior side of innervation, except for half of essentially the nail bed, half of the very distal phalange there, the skin overriding that, and it's the more medial half there, that right there. It does all but that. Yeah, I know it's kind of wonky, it's kind of weird. Why would it do that? I'm not sure if I have a good anatomical answer. It just is. But that's the layout of the ulnar nerve. Oh, hey, there you go. Now we're talking. That's a better image of the claw hand right there. So that's the hand that you would anticipate if someone has damaged the ulnar nerve one way or another. By the way, I've given you the brachial plexus end of that damage. Imagine where else could we have damaged the ulnar nerve on its long path down to the hand. There's another spot there. Oh, I see someone. Yep. Remember that on the epicondyle as it's your funny bone essentially. The ulnar nerve wraps around the medial epicondyle, and as it does, it potentially is going to get, if that medial epicondyle gets fractured or something, you could damage the ulnar nerve. You'd still get the same presentation. Okay. Speaking of the median nerve, this guy's picking up, as you can see, on the more palmar side, it's getting all of the thumb, the second digit, and the 3rd digit. All of these are being picked up by that median nerve and half of that 4th digit. On the back side, the dorsal view here, we'll see it's just the tips of those same individual digits, just the very outer portion of them. And that is because there is a portion of the radial nerve, even though we don't have any radial motor innervation in the hand. Remember the hand, the intrinsic stuff, it's all been median, it's all been ulnar so far. The radial nerve doesn't do any motor there. It does sneak in some skin sensory innervation, some cutaneous innervation, and specifically it's on this dorsal side of the thumb, and then the first couple of digits, but not at the very ends. It's kind of further back. Just a hair bit of it as well on the thenar eminence, the very kind of lateral side of that thenar eminence. Okay, so that helps out. There's 3 nerves for sensory innervation there. Kind of know those 3 general patterns and know that, for example, connecting to what we've talked about today, if carpal tunnel syndrome develops, and you can actually see a really nice median nerve going underneath the carpal tunnel right here, carpal tunnel syndrome develops, then not only are we going to have that thenar atrophy and weakness of the thumb, we're also going to be losing the sensory innervation or diminishing the sensory information in this pattern that we see on the hand right here on this image. So anywhere you see the green or the brown. Excuse me, the green specifically is the parts from the going underneath the carpal tunnel. But questions about anything we saw? Cutaneous innervation of the hand. Those three. Again, I've tried to reserve cutaneous only down to just the limited 3 here in the hand. Another reason I only allow those is because knowing the most distal ends of a nerve is almost as good as knowing the rest of it. And the reason why is if you test the most distal end, as you probably know in your HCPCS, then you have now tested the entire length of that nerve. And so you can know, okay, things must be intact if the very end here is working. Okay. All right, so that leads us into some superficial anatomy here, looking at first the cubital fossa. This is just a nice reminder to us that, again, moving from more lateral to medial, we've got the tendon, the artery, and then the nerve. Brachial artery, median nerve, passing through the cubital fossa. Excuse me, did I say, yeah, lateral to medial. Lateral being the tendon, most medial being the nerve. Some really good anatomy, of course, of the wrist. Whenever you flex your own wrist, you should be able to see very commonly what pops up is 2 muscles. The one that you probably see the most actually is the flexor carpi radialis tendon. Keep in mind 10 to 15% of people do not have this one.
Palmaris longus.
Palmaris longus, yep. So that one may not pop up on your own wrist. To be honest, on my wrist, I don't want to dissect myself, but I'm fairly certain that I do not actually have a palmaris longus because nothing really pops up upon flexion there. But I definitely can feel my flexor carpi radialis and my flexor carpi ulnaris sticking out. Those are really good landmarks, and specifically for the arteries, that's what I use all the time. Those 2, the flexor carpi radialis, flexor carpi ulnaris, if you go to either side of those 2 tendons, either more towards the thumb side of the flexor carpi radialis, if you go more towards the thumb side, of course, that's the most easy artery to palpate in the body, the radial artery right there. Hopefully, many of you have used that one very commonly. Of course, you need to relax the tendon. And then on the other side, this one being just a little bit, again, towards the thumb side, you'd find the ulnar artery. It's a little bit deeper in there, so sometimes you have to kind of palpate a little bit deeper in to find it, relaxing the wrist. But again, it's just a little bit more lateral towards the thumb of your flexor carpi ulnaris. And if you, again, flex your wrist, you'll find the flexor carpi ulnaris on one side, the radialis kind of towards the other side, and then these 2 arteries are right on either side of those 2 tendons. Okay. There's our good friends, the thenar eminence and the hypothenar eminence that are just there because of the underlying intrinsic muscles. I think we've defined intrinsic, but in case I messed up and never defined it, intrinsic just means these are structures contained within the hand. So intrinsic muscles of the hand, the beginning and end of the muscle are all within the hand. We've got lots of other tendons that are coming down that are also, technically you can think of a lot of the forearm muscles as being hand muscles, but the intrinsic muscles are contained within the hand, not crossing the wrist. And we've picked up a lot of artery range here, and so we've got a lot of pulses that potentially can be taken. Everything from an axillary pulse down to a brachial pulse mid-arm. This is, I don't know if this will be a very poor resolution, but notice the fingers being just below the biceps brachii. So biceps brachii, and then just below on the medial side, so on the side of the biceps. That's where the brachial pulse can be picked up. Keep in mind, it can also be picked up in the cubital fossa. Again, when someone's not flexing their biceps there, because that'll tighten that aponeurosis over that, making it very difficult to palpate. We just did the ulnar and the radial pulse. Oh, yes, and then we can also pick up our radial pulse in the anatomic snuff box. So, lots of places we can pick up the arterial pulses. Okay, have mercy, guys. We are done quite early, which is good. I don't think that's a problem. I was going to give you guys a little bit more time, and I'll be honest, one of the reasons why I've always ended early in both the upper limb and the lower limb is because there is a lot of just raw work for you guys to do. I hope you guys probably are recognizing that. You got the tables and whatnot before next Monday that you got to feel very comfortable with, and so we're going to give you plenty of time to do that without piling a lot of new material on you. So we're going to put it in neutral and kind of coast through this week and some other areas. But if you have questions, definitely be bringing them to class. And especially for Austin's lecture, bring your curiosity. The more curious you are, the more interested you are, the more you're going to have more glue to stick this stuff in your brains and to make it stick. Okay? Any questions about anything before we wrap up for today? Questions about anything? Okay, well, sounds good. I'll see you guys tomorrow. We'll do the quiz. After the quiz tomorrow, because we've wrapped this material up, I might have some brief videos of some of the areas that we'll kind of take a look at together. I will also start to take questions. I know it's maybe a little bit early, but still happy to take questions about anything you're studying that's not making sense from anything that we've discussed. And then we'll shift gears, have Austin on Wednesday, and go from there.